Hello everyone. Good evening, good morning, and Happy New Year to everybody. I'm absolutely thrilled to see all of you here today. Before we begin, I just want to take a moment to sincerely appreciate everyone of you for joining. This is meant to be an open and welcoming space, a place where I can share insights, ask questions, and learn from one another. For those who don't know me, my name is Zifei Liu. I am the IVF lab director and assistant professor at Penn State Hershey Medical Center. It's truly my pleasure to introduce today's speaker, Wei Zhang, who is the lab manager at Reproductive Partners Fertility Center San Diego, RPSD. Now, I don't necessarily want to remind myself how old I am, but Wei and I go way back 20 years to be exact. We were a master and a PhD candidate together back in 2005 at Zhongshan University in Guangzhou, China. We started her IVF journey in 2008. And if I remember correctly, she's now been with RPSD for 14 years. Is that correct?
Yes.
All right. So Wei is just such an incredibly talented, brilliant, and highly skilled embryologist. If I had to describe her in one phrase, I'd say she's the brain of the RPSD embryology lab. She has an extraordinary depth of knowledge in reproductive science, and I'm so excited to have her here today to present on this fascinating topic, PGT-A, to be or not to be, exploring the clinical dilemmas of embryo testing. So the question of whether or not to perform PGT-A on embryos has been one of the most debated topics in our field. Over the past 10 years, we've seen numerous research articles published on this subject. While ASRM does not recommend PGT-A for all patients, studies suggest that only a subset of patients may truly benefit. However, opinions remain divided. Some view PGT-A as an invaluable selection tool, while others question its necessity. This debate is far from settled, and I personally believe it will continue for years to come. So that's why I invited Wei to give this talk. She graciously agreed and has put in tremendous effort to prepare this presentation. I have no doubt that it is going to be insightful, thought-provoking, and engaging. I also encourage all of you to share your perspectives and experiences during the discussion. This is meant to be a true exchange of ideas, okay? So before we begin, I'd like to briefly introduce RPSD, where Wei is working at. So it is a trusted leader in fertility care that has been at the forefront of reproductive innovation. In 2000, RPSD became the first clinic in San Diego to deliver a baby through PGT-M to prevent inherited genetic disorders. In 2012, RPSD achieved the first successful birth from a frozen egg transfer in San Diego. So RPSD continues to set a standard in fertility treatment and preservation. If you'd like to learn more, please schedule a consultation or get in touch. You can visit www.fertilityclinicsandiego.com. Call 858-552-9177 or email info@rpsandiego.com. All right, so now without further ado, let me pass it over to Wei. So Wei, please, let's get started.
Thank you so much, Yifei, for the wonderful introduction. It's truly an honor to be invited to speak here today. I'm very grateful for this opportunity, especially because I personally learned so much from this group last year. And I also want to thank everyone for their contributions, with a special shout out to Yifei for the time and effort you've dedicated to this group. And as we all know that PGT-A has always been a controversial topic in clinical practice due to its limitations. Over the years, we've recommended PGT-A to many patients, particularly those of advanced maternal age. However, there have certainly been moments when we questioned ourselves or were challenged by patients asking questions like, are the embryos identified as aneuploid truly abnormal? Or what are the chances of having an abnormal baby when transferring a euploid embryo? Today, I would like to use this opportunity to explore some of the contentious aspects of PGT-A testing. Hopefully, this webinar will provide some valuable insights and inspiration for everyone's approach to patient counseling. And before I start, I would like to give a conflict of interest disclaimer. I hereby declare that I have no financial, professional, or personal relationships with any genetic company that could influence or be perceived to influence the content or conclusions of my work, communications, or decisions. So should we move forward or should we stop? Before answering that question, I would like to go over a few key areas with you. First, we'll discuss the causes of aneuploidy and mosaicism and their clinical implications. Then we'll dive into the limitations of PGT-A and how to address them. After that, we'll focus on interpreting PGT-A results and guiding your patients through counseling. Along the way, we'll also cover how to choose the right genetic lab and testing method. Finally, we'll wrap things up with some recommendations for managing the risks associated with PGT-A. Let's start by taking a closer look at how aneuploidy originates in human oocytes. I would like to share an article published in Science in 2019. It explained how natural fertility in humans followed an inverse U-curve, with lower fertility rates in teenagers, that means 13 and older, and women of advanced maternal age, middle 30s and beyond. Chromosome errors during female meiosis are a major cause of pregnancy loss due to aneuploid conceptions, especially in women of advanced maternal age. And the author of this article suggests that meiotic error rates across a woman's entire reproductive lifespan may influence natural fertility. In other words, both younger and older women tend to have higher rates of oocyte aneuploidy. And one current hypothesis for how aneuploidy forms in human oocytes is cohesion weakening. This process can lead to all three types of meiosis I errors: non-disjunction, premature separation of sister chromatids, and reverse segregation. These errors can result in the gain or loss of an entire chromosome, causing whole chromosome aneuploidy. The authors studied chromosome segregation in human oocytes from females aged 9 to 43 and found that aneuploidy follows a U-shaped pattern. Different types of segregation errors are linked to specific age groups. Explaining this pattern, in young girls, increased aneuploidy is mainly caused by whole chromosome non-disjunction events. In older women, fertility declines due to centromeric and widespread cohesion loss, which made PSSC and RS become the main cause of aneuploidy for this age group. And they also proved that aneuploidy rates were not affected by maturation method, which means no matter X were matured in vivo or in vitro, or the X cohort. That means no matter they're from small antral follicles or larger antral follicles. The aneuploidy rates were not affected by those vectors. However, the maternal age was the only significant factor that affected aneuploidy. And now let's look at the karyotype on the right. Chromosomes 1 to 5 are part of the largest chromosome group, while chromosomes 13 to 15 and 21 to 22 are classified as acrocentric chromosomes. The authors identified distinct age-dependent segregation errors with these groups. In the image on the left, you can see that chromosome 13 tends to show higher error rates in younger girls. A similar pattern is also observed with the largest chromosome group, likely because these large chromosomes are more prone to non-disjunction in younger females. On the other hand, acrocentric chromosomes are associated with higher rates of PSSC, premature separation of sister chromatids, or reverse segregation errors in the advanced maternal age group. So now that we've covered the origin of the aneuploidy, let's talk about mosaicism. Here is a key point to start with. All mosaicism is aneuploid, but not all aneuploidy leads to mosaicism. Mosaicism is a product of mitosis, but can have its roots in meiosis. Here I would like to illustrate the mechanisms of mosaicism by showing everyone some short videos presented in ASRM embryology courses. First of all, how do chromosomes segregate? Let's take a look at proper mitosis. As we all know, a normal cell has two sets of chromosomes. The chromosomes from the mother and the father are represented as blue and red, respectively. Each chromosome contains two chromatids, a chromatid from the mother or father and the duplication of that chromatid. During division, also known as mitosis, the spindle apparatus, represented by black line, develops and attaches itself to the chromosomes at a site known as cathecial, and represented as the black dot. Let me play this again. So the spindle pulls the chromosomes apart and each chromatid goes to opposite poles. The cell then divides, creating two identical cells. Unfortunately, mitosis does not always occur as planned, leading to aneuploidy and the subsequent mosaicism. One mechanism by which mosaicism occurs is referred to as non-disjunction. Instead of, let me play the non-disjunction. So instead of each chromatid migrating to opposite poles, one chromosome fails to separate and the entire chromosome, both chromatids, are forced to the same pole. This creates a game that refers to as trisomy in one cell and a loss or monosomy in the other cell. Non-disjunction seems more prevalent at certain stages, particularly meiosis 1 and 2 among the autosomes. The first cleavage division seems especially prone to non-disjunction. And now let's look into the premature separation of sister chromatids. So this is the oocyte surrounded by the zona pellucida. The oocyte must undergo two reduction divisions, meiosis, that is meiosis, to get from 4N to 1N. During normal meiosis, the first division results in the reduction of chromosomes from 4N to 2N. The second division results in the reduction of the oocyte from 2N to 1N. However, even meiosis doesn't go as planned. The most common error at this stage is premature separation of sister chromatids, which results in the first reduction division of one chromosome as opposite to the usual two chromosomes. Ironically, oocytes that undergo premature separation of sister chromatids can make up for the error in the subsequent M2 reduction division. And euploid embryos have been diagnosed from oocytes that have undergone premature separation of sister chromatids. Another mechanism is referred to as anaphase lagging. I'm sorry, I lost my mouse. Okay. During anaphase lagging, a single chromatid fails to be incorporated into the nucleus. And this creates one cell with proper number of chromosomes and another cell with a loss of or monosomy. Anaphase lagging can create an aneuploid cell line. However, it also corrects a trisomy cell line back to euploid status, and that is a phenomenon known as trisomy rescue. And I will discuss that later. Another name for the last one mechanism that is endoreplication. We also call it polyploidy. Endoreplication does occur, although to a much lesser extent than anaphase lagging and non-disjunction. In essence, endoreplication is chromosome replication without division. what if the nanophase lagging event occurs on a chromosome that has 3 copies? So in this example, there are 3 copies of chromosome 5. If a nanophase lagging event occurs, one of the copies of the chromosome fails to be incorporated into the nucleus, thereby creating 2 euploid cells from a trisomic cell. 2/3 of the time, this will result in an euploid and a corrected cell line. And 1/3 of the time, this process will result in uniparental disomy. So simply put, uniparental disomy, which we call a UPD, instead of a copy of chromosome from each parent, one from the mother and one from the father, the chromosome in question gets 2 copies, both from one parent. And the incidence of UPD is pretty low, it's less than 1%, but UPD can lead to live birth. The one we know well is the parental UPD of chromosome 15 that can lead to Angelman syndrome. And the maternal UPD of chromosome 15 will lead to Prader-Willi syndrome. And I would also want to mention there are 2 types of mosaicism, general and confined. General mosaicism occurs when 2 or more cell lines that are mitotic or meiotic in origin are present throughout the entire individual. Meiotic in origin does not mean the mosaic cell line in question derives from meiosis. It simply means that the mechanisms may be faulty from the onset. Confined mosaicism is mosaicism that is present in only a particular area. For example, if the individual is euploid and the brain contains a cell line that is aneuploid. Other areas that could present with mosaicism are the gonads, placenta, and skin, among others. The majority of research in this area deals with a phenomenon known as confined placenta mosaicism, or CPM. Simply, CPM is a chromosomal discordance between the fetus and the placenta. CPM is believed to occur in approximately 1% to 2% of all placenta tissue analyzed and has been linked to intrauterine growth restriction, spontaneous abortion, intrauterine death, stillbirth, and abnormal placenta function. There are 2 types of invasive procedure we may all know that utilize in prenatal testing. Chorionic villus sampling, CVS, and amniocentesis. Those procedures determine the chromosomal constitution of the fetus by sampling extra embryonic tissue rather than the fetus proper. CVS involves sampling from either the cytoblast or the extra embryonic mesoderm. Alternatively, amniocentesis involves the sampling of amniotic fluid. So what is important is that none of these tests directly analyze the chromosomes of the fetus proper. And regardless of whether mosaicism is present in the entire individual or confined, the mechanisms by which mosaicism occurs are the same. And let's now talk about the origins of mosaicism. It can originate from paternal or maternal and also could be external. And as we all know, the centrosome is inherited from the sperm and is responsible for the first mitotic division within the human embryo. Therefore, any disruption of the sperm centrosome can theoretically produce mosaicism in the pre-implantation embryo. Sperm ester formation has been shown to be delayed in infertile males when compared with fertile male controls. This could cause a delay in sagamy and also subsequent cleavage and possibly induce aneuploidy and mosaicism. There are several studies that suggest that aneuploidies are more prevalent in men with severe male factor infertility, indicating the importance of a functional sperm centrosome in the first mitotic divisions. So if aneuploidies are more common in men with severe male factor infertility, then it is possible that mosaicism may also be more prevalent during pre-implantation development in this group of patients. And for the maternal origin. As we all know, our ROS level increase when women age, and also environmental factors can contribute to that. And we also mentioned about the weak cohesion between sister chromatids when women get old, maybe another culprit for the abnormality or aneuploidy. And also downregulation of mitosis genes, spindle abnormalities, those are all could be the origin of mosaicism from the maternal side. External. So we've heard a lot of articles, or we've seen that published that discussing that different labs may have different level of mosaicism rate, which could be true because different labs using different hyperstimulation protocols and there is difference between centers and protocols. Also, their embryo culture system is different. And we all know poor conditions will contribute to poor embryos development, and that will also increase the incidence of aneuploidy. And also biopsy techniques can contribute to mosaicism level. Poor biopsy techniques definitely will contribute to higher mosaicism. And also difference among different genetic labs. We have to be aware their bioinformatic algorithm. That may be another factor can contribute to different levels of mosaicism. Now let's dive into the topic of PGT-A limitations and outcomes and how we should counsel patients accordingly. When discussing PGT-A limitations, there are definitely some important questions we need to address. And I'm pretty sure people among us, we have been challenged by patients about these questions. What is the PGT-A accuracy? What is your mosaicism rate? And what is the incidence of a segmental aneuploidy? What is your non-informative rate? And is it cost effective with my age group to proceed with PGT-A? Will my embryo get damaged from the biopsy procedure? What kind of genetic lab you are using? Is it reliable? And who can be benefit from the PGT-A procedure or testing? Is it the advanced maternal age group or advanced paternal age group or recurrent pregnancy loss group? So we're going to cover those areas with today's presentation. So first, we'll talk about the accuracy of PGT-A. So when we talk about accuracy, there are two concepts we cannot ignore: the predictive value of PGT-A, negative predictive value, and the positive predictive value. So negative predictive value means the chance that a euploid embryo will produce a euploid pregnancy. That has been widely reported and well established. And then positive predictive value means the chance that an aneuploid embryo will not produce a pregnancy. Limited study and some are biased because of patients selecting or not prospective. And I would like to introduce a published paper, which was on 2022. So it's a non-selection trials, and it proved a very high positive predictive value of aneuploid embryo. It proves that uniformly whole chromosome aneuploidy provides 98% of predictive value for early lethality and 86%, almost 86% of miscarriage rate. Almost never, transferring aneuploid embryo almost never associated with live birth of a healthy baby. So with that said, disposal or deselection of uniformly aneuploid embryos is expected to have no meaningful implications for cumulative live birth rate in IVF cycles with PGT-A. And now let's talk about a mosaicism. And when we talk about a mosaicism, when we see a chromosome mosaicism diagnosed in a trifecta cells biopsy, we have to be aware it doesn't mean direct witnessing of those euploid and aneuploid individual cell. It actually just means the presence of an intermediate chromosome copy number. That means between monosomy and disomy, or between disomy and trisomy on the NGS profile. So a lot of us probably have been questioned about the aneuploidy incidence in the clinical tryptophan cells biopsies and also the embryonic concordance. So I would like to introduce this article to everyone, which was published on 2021. It's a prospective multi-center double-blinded non-selection study, and also unbiased comparison between uniformly euploid and the mosaic embryos in terms of reproductive potential. So it reported that chromosome mosaicism is in up to 20% of clinical tryptophan biopsies, and smaller chromosomes were more frequently represented than others. And now let's talk about the embryonic concordance when we see an euploid in our PGT A result. So when we see a euploid in a single tryptophan cells biopsy outcome, that means the ICM are really affected. The chance of the ICM get affected based on this report is around 0.2%. And when you see a low-level mosaic embryo, that means the chance for the ICM got affected maybe around 0.6%. And when it comes to medium-graded mosaic embryo, the chance for the ICM get affected is around 2.2%. And high-grade mosaicism is in another story. So if a result shows a high-grade mosaicism in a single tryptophan cell biopsy, that means that embryo commonly associated with a uniform aneuploidy throughout the embryo, including the ICM, and the chances can go as high as 65%. I can just
turn the video off. Okay, all right, let's get started.
After all, this published article also gave us insights about how much percentage of live birth rate we may potentially lose if we don't transfer the low level and medium level grade of mosaic embryos. So based on their observed model, that means actual data from this trial, if we're not transferring the low level and medium level mosaic embryos, we probably would expect overall reduction of 24% live birth rate. And with the optimistic model, that means combined probability of live births in the case of all transferable embryos are utilized. If we choose not transferring low level and medium level mosaic embryos, we may expect overall reduction of 36% of live birth rate, which to us, it could be tremendous. And we just talked about the low level and medium level mosaicism. They have the similar reproductive potential compared to euploid embryos. And we're still seeing so many mosaicism in our report. Now it's a question that we should ask ourselves. Is it time to stop reporting them? And I would like to share this opinion that was published on 2023, which is very interesting. You know, we all know when there is a true signal indicating that a true mosaicism that might indicating, you know, mitotic segregation errors, which can caused by embryology lab conditions or stimulation protocols, and then a lot of other factors can impact. But we also have to be aware there are some other factors that can artifact your result, and that those can be concluded as technical noise, the contamination, and also amplification bias, the number of tryptophan cells you biopsied, and the biopsy technique, if you get enough intact cells, if you're getting the fragmented cells, and also the bioinformatic algorithm from the genetic lab you're using. Those could also be the false positive or negative, you know, mosaicism that you're getting. So I would say if you're choosing to use a full mosaic report, I think all the labs, you know, should closely watch your mosaic rate. And if there is a constantly high incidence of mosaicism identified in embryo cohorts within a given clinic, I think we should really take into serious consideration and investigation and see where could the problem come from. And also, it's very important to know the mosaicism cutoff range from the genetic lab you are using. because different genetic lab, they may use different cutoff. So for example, if you're using the 50-50 thresholds, that means it's almost like just euploid and aneuploid report. But if you're using the 30 to 70% thresholds, which is more stringent, and that's what iGenomics is using, that means you may probably expect a lower mosaic rate in your report. And if you're using the less stringent cutoff, which is 20 to 80%, and that is Cooper Genomics using, then you may expect a higher mosaic rate in your report or in your result. I'm sorry. I think there is no right or wrong what kind of report you choose to use, but you have to, be open to your patients and clarify with your patient, or maybe even indicate it in the patient consents. And I would like to give a case review with everyone, which we have experienced in our clinic. So we had a 28 years old woman who had an IVF cycle with PGT A and PGT-M. So she had a bunch of euploid embryos, or embryos that are suitable for FET. She transferred one PGT A, PGT-M normal embryo. She got pregnant. However, the amniocentesis result revealed a trisomy 18. So we contacted genetic company right away, and genetic company also performed discrepancy investigation. But patient decided to continue pregnancy, even by knowing the risks. After giving birth, the SNP confirmed the trisomy 18, and the baby died 5 days after delivery, which is very tragic. So the discrepancy investigation from the genetic lab ruled out the spontaneous conception, lab sample swab, unintended embryo transfer, cumulative cells contamination, also external dermal contamination, etc. But what is the culprit in this case? I would say mosaicism. And what is the chance for us to get in this kind of outcome? It's only 0.2%, which I just indicated from the article that published on 2022, indicating if you're transferring a euploid embryo, how likely the ICM will get affected if that could potentially happen. And the percentage is only 0.2%. So we should also want to cover some aspects regarding segmental aneuploidy. Is it true, or is it false? So we just talked about, as co-chromosome aneuploidy, the positive predictive value towards ICM configuration is 98%. Because as we all know, whole chromosome aneuploidy is prevalent, prevalent meiotic origin. However, segmental aneuploidies, majority of them, almost 70%, arise from mitotic errors. So that means segmental aneuploidies can be random. And the literature published in 2019 saying that full and mosaic segmental losses are most frequently of paternal origin and could be caused by fragmentation during spermatogenesis. That even more said that segmental aneuploidy sometimes can be random, and that's why also explained segmental aneuploidy has the lowest concordant rate. And this paper, which was published in 2020, it gave us insights about the incidence and type of segmental antibodies in human embryos. So the incidence of at least one segmental aneuploidy is around 5.6%. And the percentage of carrying a segmental alteration alone is around 2.4%. Larger chromosomes were more frequently involved with segmental aneuploidies. The incidence of segmental aneuploidies was not related to female age, as we just talked about. Majority of them originated from mitotic errors. So as clinic practice, how should we handle those segmental aneuploid embryos? How should we counsel our patient accordingly? So this article also gives us some clinical management guideline if we are facing some scenarios like this. If patient only has segmental aneuploidy, if the second biopsy confirmed segmental aneuploidy, then the ICM, the chance of the ICM got affected or being aneuploidy could be as high as 84%. However, if the second biopsy did not confirm segmental aneuploidy, then the chance of the ICM got affected or confirmed as aneuploidy may be only around 20%. So in cases in which a segmental aneuploidy is the only abnormality, we probably should recommend second biopsy. And another published article also revealed a similar result. So it shows if second biopsy discordant with the first biopsy for a segmental aneuploidy, true negative rate could be 92.3%. That means most likely the embryo is euploid if both biopsy reveal the same. And if the second biopsy concordant with the first biopsy, true positive rate is 94.5%, which means most likely the embryo is aneuploidy. So second biopsy might be the solution for a confirmation for those embryos that are diagnosed as segmental aneuploidy. Now we talked about the mosaic embryos. We talked about segmental aneuploidy. And I believe majority of you have read this article that published on fertility and sterility on 2020. So it used outcome data from 1,000 mosaic embryo transfer to formulate an embryo ranking system for clinical use or guidance. When we have mosaic embryos, we probably may choose those embryos that only has segmental mosaicism as the first priority choice. And if there is, and the second criteria we may choose is the low level with 1 chromosome, and then low level with 2 chromosomes, and then low level with complex. The bottom will be high level mosaic. And this also correlates with their clinical outcomes. And I would like to give another case review to everyone, and I would like to know what would you recommend if you experience this kind of case. We have a 43 years old single female. She had 2 IVF cycles. So after 2 IVF cycles, she had 1 euploid embryo and also 1 high-level mosaic segmental aneuploid day 5 4BB embryo. Also a high-level mosaic segmental deletion, day 5 4AA embryo, mosaic embryo, high-level mosaic. So she transferred a euploid embryo back on 2023 and she gave birth. Now she came back last year or last month and she tried another IVF cycle, but no blastocysts. And she's 43 years old. So she's debating whether to transfer these 2 high-level mosaic embryos or not. So I would want to know, what will you recommend if you are experiencing this kind of case? Would you recommend recommend patient to transfer for AA high-level mosaic? Or would you recommend B, recommend another IVF cycle? Or you will recommend C, recommend donor oocyte cycle to this patient? Or D, rebiopsy those 2 high-level mosaic and wait for the confirmation result. And Ibe, do you mind counting everyone's choice in the chatting area?
Yeah, so we are having those the polls. So people are making their decisions.
Thank you, everyone.
Still voting. Can you actually see it, the poll?
Yeah, I can see 20 out of 21 out of 22, now 22.
Yeah, as we speak, 12 out of 23 is basically 54, like 13 out of 24 now. This is basically half of people choose to transfer the 4AA high-level mosaic embryo. 2 out of 24, 8% recommend another IVF cycle. 2 out of 24, 8% recommend donor oocyte cycle. And 7 out of 26 now, 27%, rebiopsy those two high-level mosaic and wait for the results. Confirmation.
I see. So choice D got the most votes so far.
A, actually.
Oh, A.
Yeah,
Wow.
more than 50%.
Wow, very interesting.
Yep.
I see. So in this scenario, we didn't give an exact recommendation for this patient. Actually, I was the one who counseled this patient. So she had a very good bonding with us embryology lab, and she was really, debating what she should do. So the last conversation we had, she doesn't want to just go ahead and transfer the high level mosaic because she was worried about the miscarriage. If she end up having miscarriage, then she will, her uterus or her body will have to rest another time period. And she feel like it's wasting of her time. She would rather save her healthy uterus either for another IVF cycle, which she may potentially get a euploid embryos, or she could save up her healthy uterus for another like donor oocyte cycle. So by knowing that, I recommended to her, why don't you rebiopsy those two embryos? Because quality-wise, they're very decent, especially the trifecta cells are graded A and B. So maybe you can rebiopsy those two embryos and wait for the confirmation, and at the same time look into donor oocytes. And I also went over all the stats with her. So eventually she chose to rebiopsy those two mosaic embryos and waiting for the confirmation. At the same time, looking into donor oocytes, frozen donor oocytes from egg bank. We haven't got the confirmation result back yet. I will keep everybody updated once we get the results back. And at the same time, I also went over the pros and cons, because if you're doing rebiopsy, you potentially could throw those monies into the drain because the result may come back as the same. Then you will not end up transferring those embryos. And for rebiopsy, she will have to spend another $3,000-4,000. She have to pay us the biopsy fee because it's resulted. It's not free, so we have to charge her. And at the same time, the genetic lab will charge her for the testing fee. So those 4,000 to 5,000 potentially may go to the drain, and she can potentially save that money for a donor oocyte cycle, but she chose not to. She knew this probably her last chance that potentially can get a euploid embryo from her own genes. Okay, I think we can have more discussion towards the end. I'm just gonna go through all the slides first. Okay, so now we're gonna talk about another limitation that PGT A we have had all faced. It's no result. Should we rebiopsy those no result embryos or not? So based on the publication published on 2018, it shows the no result incidence is around 2.5%. And what the genetic lab always quote us is around 2 to 3%. If you're experiencing more than 5%, you really should look into your biopsy techniques. So based on this article, the no result rate was not affected by blastocyst morphology, was not affected by maternal age, but it varies between biopsy centers or by IVF labs, and also affected by the day of the trabecular cells biopsy performed. That means if you have a day 7 embryo biopsy, you may potentially experience lower no result rate. But of course, I think that the data that published might be different from what you have within your clinic. So I think getting your own data is more important. And based on what Cooper Surgical data published 2021, they gathered 554 no result embryos. Out of those, 231 went through rebiopsy. And out of the 231 embryos that went through rebiopsy, almost 97% have survived the thaw. 26% came back euploid, 55% came back as aneuploid, and 7% come back as no result again. And they transferred 31 euploided embryos, 15% clinical miscarriage rate, and almost 36% live birth rate. And with those no result embryos without rebiopsy, there are 42 of them. So 67 survived the thaw, 67% survived the thaw, 41 embryo transferred, and they got 36 clinical miscarriage rate, which is much higher compared to the other group that went through rebiopsy. And because they were confirmed as euploid when the result come back the second time. However, it also get a much lower live birth rate, it's 17%. And at the same time, I would like to share recent published article, which was last year. And I quoted this very cute picture that was illustrated by Diana Tan on LinkedIn. I think it can illustrate this paper in a very straightforward way. So this article or this systematic review and a meta-analysis, they used embryos that went through biopsy either on day 5, day 6, or day 7, and also transferred as euploid. And they only went through one biopsy, one vitrification as a control group. And they also compared the other two groups that we definitely have faced in our clinical management. One group is the embryos that came back as no result, and patient choose to rebiopsy. Those embryos went through 2 biopsies and 2 vitrification. And the other group is patients, at the first time, they chose not to test those embryos. So they froze in those embryos without PGT A testing. But later on, for any reason, they decide to thaw those embryos and perform PGT A later on. So that group are the embryos that went through 1 biopsy and 2 vitrification. So compared with the control group, the embryos that have been no matter biopsy twice or once and vitrified twice, they had a significantly lower clinical pregnancy rate and live birth rate compared to the control group. So whenever we consult our patient, when patient wants to rebiopsy the embryos, we need to make them be fully aware about the risk and also, the jeopardize on the clinical outcome. And now we will talk about chaotic embryo. So what's hiding behind? Chaotic embryo, based on iGenomics interpretation, it means that embryo has 6 or more aneuploidies detected by PGT A. Normally, it's not recommended for transfer, but it can be rebiopsy to confirm. And the incidence of chaotic embryo is around 2 to 3%. And the ICM and surfactant quality are significantly associated with chaotic result. So good quality embryos may experience 1.6% of chaotic rate. However, the poor quality embryos may experience almost 4% of chaotic rate. And of all parameters evaluated, the highest rate of chaotic results was observed for embryos with a C-graded trabecular cells, C-graded trabecular. So which means when you have poor trabecular cells, you may end up having a chaotic result. And you may have higher chance to get a chaotic result. And the incidence of chaotic results increase with the day of biopsy. When you biopsy on day 7, you may experience the highest chaotic rates compared to day 5 and day 6. And that's the data published 2023 ASR as abstract. And we'll look at another 2 abstracts published, one on 2021 in SPAN annual meeting, and the other one was published on 2022 in ASRM. So chaotic embryos in general, based on the studies that we've seen from these 2 studies, it has around 35 to 40% of chance come back as euploid if rebiopsy was performed. However, trifractodome cell quality and day of biopsy should also take into consideration. I don't know about other genetic lab, which, we can ask and the genetic lab you're using, but iGenomics offers no charge for rebiopsying chaotic embryos. So rebiopsy, will it really solve the problem out of time? I think we should really think about that question because not all embryos are the same, especially when it comes to quality. The study published fertility and sterility back on 2016. These 2 studies kind of gave us some inspiration or insights. No result rate decrease as cells biopsied increase, but plateaus at around 6 cells. So it's not always the more, the better. And also the number of trifractodome cells taken at biopsy impacts clinical outcomes. So which means if you biopsy tremendous cells from an embryo, definitely you are potentially jeopardize the reproductive potential of that embryo. And particularly in blastocysts with grade B or C trifractodome. That makes sense because especially with embryos graded as C, that means the cells are already sparse. And if you biopsied a good amount of cells out of those poor trifractodome cells, the percentage you are taking out, it can be considered tremendous, and that will definitely impact the implantation potential for that embryo. Okay, now we're going to have another case review, and I would like to see what audience would like to recommend to your patient. We had a 40-year-old patient. After first IVF cycle, she got only 1 3BC poor blastocyst on day 6 out of the 10 mature or M2X we inseminated. After PGT A testing, the PGT A result shows non-informative. So what would you recommend to your patient? Choice A, rebiopsy and wait for a second biopsy outcome. Choice B, go ahead and transfer them both. Choice C, save this embryo as a, go ahead and transfer this embryo, not both. Choice C, save this embryo as a backup and go for another IVF cycle. What would be your choices or recommendation? Yifei, could you please start a poll?
Yeah, I think people are voting right now.
Thank you.
So far, 2 out of 3 account for voted for the interesting. All right, 9 out of 13, 69% choose the third option. So 4 out of 14, 29% choose the first option.
What is the highest?
C.
C?
Yeah, over 60%.
Okay.
The second is the number A. The option A, rebiopsy and wait for a second biopsy outcome.
I see. So how come I got a? So actually, that's what the patient chose. She chose to save this embryo as a backup and go for another IVF cycle. We went through the pros and cons with the patient, how much you would need to pay. And I know go for another IVF cycle can be costly, and also she may have no blastocyst the second time. But if you choose to do rebiopsies, no charge, but the implantation potential might be impacted because, this embryo was graded as S3BC. So we may experience a dilemma when the embryo even though the embryo comes back as euploid, the implantation potential might be tremendously jeopardized. So after the thorough consultation, patient did choose C. Okay. So I've always talked about, we talked a lot about the KPIs for IVF lab, about the blastocyst formation rate, ICSI fertilization rate. I know those are very important, and we are actually actively monitor those KPIs, I believe among all the IVF labs. But since nowadays we're doing so many PGTA cycles, I believe in California, majority of the lab, they are doing more than 80% of PGTA cycles for patients. Since PGTA have been so widely involved, I think we should also have some PGTA KPIs. We should really closely monitor our mosaicism rate, the segmental aneuploidy rate, also chaotic and complex aneuploidy rate, aneuploidy rate among all age group, no result rate, euploid implantation rate. And then if you have any other suggestions, I would love to hear from you, in the chatting area or later in our Q&A section. So the reason I think we should really closely monitoring those rates is because mosaicism or like segmental aneuploidy rate can originate from mitotic errors. And those can potentially be contributed by culture system or poor culture system or poor stimulation protocol, poor biopsy technique, and it can even varies among different technicians. So if you're experiencing high aneuploidy rate in young age group, what does it tell you if, all other IVF labs are using the same genetic labs with you, and your lab are experiencing high aneuploidy rate for the young age group? I think we should, if we're ever experiencing that, I think we should really look into, our system and to see what can contribute to that high aneuploidy rate for a young age group. And if you're also experiencing low implantation rate for euploid transfer, is that something you should think about, if it's the biopsy techniques, or it could be, the culture system. And if you're experiencing very high mosaic rate and also your PGTA cycle outcome is even worse than non-PGTA cycles, I think there are a lot of things to look into, and we should find out if it's a systematic issue or just random. So talking about PGTA, who will be benefited? Is it the advanced maternal age group or advanced paternal age group? So based on the literature that I listed here, PGTA may have a beneficial role in patients of advanced maternal age group, especially those with good ovarian reserve. However, with advanced paternal age, we all know embryo aneuploidy and paternal age has no strong association. Even though for a male whose age are more than 50 years old, they might experience higher segmental aneuploidy, but it doesn't mean routine PGTA should be recommended as, for those age group as a routine. And I know nowadays, the patient who choose to use donor oocytes, they wanted to do PGTA too. But as health providers, embryologists or REI physicians, should we recommend a PGTA to those kind of group of patients? So based on the literature published, overall, the totality of the evidence argues against the routine use of PGTA in donor oocyte cycles. And it might be very costly for them because they already spend so much on donor oocytes, and no matter it's frozen donor oocytes or fresh donor oocytes. And I know probably majority of you are still on the fence regarding PGTA because we've challenged the by patients. Well, my embryos got damaged by biopsy procedure. So based on the internal data we have and also the data published, we always tell patients biopsy procedure is an invasive procedure. I would never say it has zero risk or it will have no impact on the embryo implantation potential. But based on the data that we have, that we have seen published and the data that we have from the internal side, we didn't see embryos got implantation potential got jeopardized just because of the biopsy procedure. But if your clinic observed lower survival rate and the lower implantation rate after PGTA, I think you should investigate it right away. And we also, when we get the result from the genetic company, there are embryos come back euploid either from day 5, day 6, and day 7. And as embryologists, we have had some questions from physicians asking you, which one should I transfer? Should I transfer the day 5 euploid or day 6 or day 7? So if your clinic, your internal data shows that day 5 has significantly higher implantation rate or live birth rate, then maybe you should recommend that to your physician or have your physician recommend it to your patients. But among the publications that we have had, it shows day 5 euploidy may generate similar live birth rate compared to day 6 euploidy. But day 7 euploidy definitely has lower potential. So between day 5 and day 6, there is no strong preference. But among day 5, day 6, day 7 probably will be the broader choice. So PGTA, a lot of patients need to spend a lot of money on the PGTA testing. And the patient may ask you, is it costly for me for my age group, or is it cost effective for my age group to proceed with this testing? And we always go over the cost with PGTA to patients and also the cost without PGTA. So cost with PGTA, the embryo biopsy fee can be very expensive. That fee alone, charged from the lab, from our IVF lab, can be $3,000 to $4,000. And the genetic lab fees is not cheap at all. So it really depends on how many embryos you have, and that can vary from like several hundreds to several thousands. And possibly patient may need to have retest the embryo if it's no result or for confirmation reason. And patient may need more IVF cycles if no euploid embryos are retrieved. And benefit is still controversial, especially with young age group. However, the cost without PGTA, we should go over that with patient as well. So if patient opt not to do PGTA, potentially they may go through more FET cycles. Each one of them may cost up to $3,000. And potentially more miscarriages and DNC fees may be involved. Potentially prolong the time for patient to get pregnant, especially advanced maternal age group. Patient may thaw and biopsy frozen embryos later on for gender selection to balance the gender of their family or after several failed FET cycles. If patients end up doing that, they may end up paying a lot more compared to they choose to do PGTA at the first place. So there is actually literature published regarding PGTA, whether it's costly or cost effective, back on 2018 and 2019. So it's very interesting, when I read through the articles. The one that published 2018, it indicated that PGTA might be very costly if patients only have one blastocyst available for PGTA. It makes sense because the biopsy fee might be flat fee, and then patient end up paying thousands just to biopsy one embryo. Also, but the thing that I want to mention is PGT-A, based on this literature published, it decreased the time in treatment by 4 months. So that means patient may go through less transfers and the less miscarriages. And the other article published in 2019, patients with advanced age and more blastocysts, they may find PGT-A more cost-effective, and that's what we've observed within our practice. So there is another case review that I would want to share with everyone, and I would like to see what would you recommend. So we had a 33 years old female went through her first IVF cycle. She got 2 borderline poor blastocysts on day 6. What would you recommend? Would you recommend her move forward, choice A, move forward with PGT-A, or choice B, frozen embryo transfer with both 2 embryos without PGT-A? Choice C, freeze without PGT-A and start another IVF cycle right away. What will be your choice or recommendation?
Okay, I think now we have divided opinions on this one. I give like maybe another 30 seconds, then people to finish their voting. So still seems to be like very close. Now see some difference. Still going. All right, I think we got 5 out of 17, which is 29%. Audience choose A, move forward with the PGT-A. 6 out of 17, 35% choose FET with both embryos. And then the other, like 1/3, choose the third option. The 6 out of 17, 35%. Freeze without PGT and start another IVF cycle right away.
I'm just curious. The ones who chose number A, are they all from California? California are very aggressive with PGT-A testing. So there is really no right or wrong what you recommended to your patients. But what I would suggest is, before we give any recommendation, really what important is, we're trying so hard to provide as evidence-based guideline or counseling to patients. So there are several data I think we need to have before we give any recommendations. First, what is your BC poor aneuploidy rate for different age group? Your internal data that you can provide to your patients. And second, what is your euploid BC poor blastocyst implantation rate? Third, the percentage of cycles of no euploid blastocyst among different age groups. 4, how much does patient need to pay for biopsying 2 blastocysts in your clinic? Because there are some patients, they have no insurance coverage, they pay everything out of pocket. So financial is a very important factor they're waiving. And also the last, how much will patient need to pay per frozen embryo transfer? So because of that, we do a lot of quality assurance studies in our clinic. And these are just, 2 simple ones that I would like to share with everyone. Because we do a lot of patient counseling. And when we counsel patients, we cannot just, give a personal recommendation because we thought it could be beneficial for the patients. We always quote data that we performed, the studies that we performed, or we quote data from the published article. So I think gaining all these internal data will give you a lot of power when you guide your patients to make decisions, and will make your clinic or whether your lab be more evidence-based. And the last, please bear with me. I know it's a long talk. I think we're getting to the end, and we're seeing the light from the end of the tunnel. I would want to talk about how to choose the right genetic lab service for your patients nowadays, and also the right genetic, testing. Nowadays, a lot of genetic labs are on the market. iGenomics, Cooper Genomics, Luminary Genetics, they are probably the main ones, and they have different names for their newer technologies. Some of you probably have heard like the terms of PGT A plus, PGT A complete, PGT A link. So essentially they are the same. They're using NGS plus SNP as the platform. I mean, at least this new technology, they can provide us for ploidy check the ploidy status for the embryos. And they can also do sibling QC, rule out a mixed up. And also they can check another, other DNA contamination. So before we get these services from the genetic lab, I would want to suggest all the lab directors or managers, maybe you can get the data, about how many blastocysts your lab biopsy each year. So maybe you can bargain for the best of price for your patients. And I know now recently Cooper Genomics offered PGT A complete that can check aneuploidy origin. Some of the patients are really into that because, some couples, they kind of blame each other when they're infertile. Women think it's the men's fault and men think it's the women's fault. So they would want to use the PGT A complete and check aneuploidy origin. So we always have to tell patients, this kind of test, there are a lot of things we don't know. There is no published data yet, and it may not work for monosomy aneuploidy, and we don't know about their non-informative rate. It might be beneficial, but I think we should be cautious when we counsel the patients, since mitotic origin sometimes may be random. Let's say, give an example. If a patient's result showing majority of the aneuploidy originated from the male, as her physician and embryologist, should we recommend her using donor sperm? Or on the opposite side, if the majority of the result shows the aneuploidy originated from female, should we recommend the patient using donor oocytes? I think either we recommend a patient use donor oocytes or donor sperm just purely based on the PGT-A complete result could be very irresponsible. So I think we should be precautious when we looking at this, result from PGT-A complete. And the other thing, PGT-A complete, it can detect the UPD, and like we just talked about what is UPD. So that's maybe another benefit. So towards the end, I would want to wrap it up by talking about some risk management when we utilize PGT-A with our IVF cycles. So we should really improve and perfect our patient consent. If not, we should go thoroughly with the patients during their initial counseling regarding the aspects below. So we should let patients know the expected frequency of your mosaic results, and you can get those results from your genetic test lab or genetic company. And also we should let patients know the technical and the clinical difficulties in interpreting mosaic PGT-A results. We should let them what truly mosaic result means and what the potential reproductive, outcome they can generate. And limited outcome data, we should also let them know limited outcome data available and potential challenges associated with making embryo transfer decisions in the absence of clear risk information. And also we need to let them know the potential outcomes of chromosome mosaicism, including congenital anomalies fetal growth restriction, and other adverse perinatal outcomes such as fetal or neonatal demise. The clinic's policy regarding the transfer and the storage of embryos with mosaic embryos, because we had been questioned by patients. How would you handle my mosaic embryos? Will you just discard them without asking us? Or what is the policy, in your clinic? So I think we should really specify that in the PGTA consent and let patient know. The last but not the least, the option to decline PGTA, they have the option to do that. Or, if your clinic is reporting the embryos without mosaicism. So if that's the case, you should let patient know what kind of report you're using. Is it a full mosaic report or it's a non-mosaicism report? And by doing that, potentially, we can avoid some uncertain results in the burden of decision-making regarding transfer or storage of embryos diagnosed as mosaic. And the reason I brought this up is because recently or last year, on October, there is a class action lawsuit against those big genetic companies in the United States. We are not involved as clinical IVF practice, but we are part of it because our physicians are the ones who signed the requisition. And our embryologists are the ones who perform the biopsy and send our cells to genetic company. And for us, we consult patient, we are involved with their PGTA decision. So I think by witnessing that, we should really think about how can we improve and perfect our consent on our end to avoid any legal issues in the future. We don't need a lot. One legal issue can really crashes or trashes, all the reputation that we build over the years. So these are really something we should take into consideration and really think about it. Okay, the last, a case review. So in the last couple of years, I would like to share some patient cycles with you that we think is very interesting. So patient 1, she had 2 FET cycles. The first FET cycle, she transferred at day 6 euploid 4BC. It failed. Second FET cycle, she transferred at day 6 low mosaic 3AB, and she had a live birth. So patient 2, first FET cycle, she transferred at day 5 euploid 3BC, failed. Second FET, she transferred at day 5 low mosaic 4AB. She had a live birth. Third patient with first FET, she transferred at day 6 single chromosome high mosaic 6BB, failed. Second FET, we transferred at day 6 complex high mosaic 4AB. Now she's ongoing pregnant, having ongoing pregnancy. So by seeing that, recently, one of our physicians came to us, our lab, and asked us, he had a 35 years old patient, and that patient got 2 blastocysts. I'm sorry, I'm losing my mouse again. So that patient got 2 blastocysts. Number one is day 5, 4AB, low mosaic segmental aneuploidy. And number 2 is a day 6, 4BC euploid. Because of those 3 cases, the physician was asking us, I want to give the best chance to this patient for her first FET cycle. Should I transfer embryo 1 or should I transfer embryo 2? What will be your recommendation? What would be your choice?
Okay, people are voting. Still going. I think it's all right. I think it's the end of the voting. So 70%, 16 out of 23 voters chose transfer embryo number 2, option B. 7 out of 23, which is 30%, audience chose to transfer embryo number 1.
Okay. So to be honest, there is no right or wrong, whether you choose A or B. But there are some legal risks we should be aware or we should think about. So if you choose to transfer number 5, over number 1 over number 6, I know we all have good intention. We want to give the best chance to this patient as her first transfer cycle. But we have to think about it. If you're choosing morphology over euploidy, then the patient may question you later on, why did you even recommend a PGT A testing to me, at the first place, if you think morphology will be your first, screening criteria? And then they may also ask you or question you, if you're recommending me to transfer 4AB, low mosaic over the euploidy, then that means you don't think your 4BC embryo has very high implantation potential, or you probably even think it's very low. Why would you even biopsy it to start with? So those are the things we need to think about. When patient has a euploid embryo and we choose a low mosaic over the euploidy just because the morphology is better, we have to think about patient may started to worry about this embryo from since day one. They may keep thinking, will I get an abnormal baby? Will I get a miscarriage? Will I wake up a bloody, pants the next day in the morning? So it's a lot of mental burden for them. If you kind of, specify that at the beginning, you tell patients, our screening system are based both on PGT A testing and together with the morphology selection, then that's probably easier for a patient to accept, instead of you tell them, what, I think we should transfer this because it may potentially have higher rates, it has higher morphology. Patient may accept it well, if you let them know at the beginning, what is your policy? What is your screening system? What is your selection criteria? And some clinics may also have time lapse and they observe embryo development over the days. So that can be added on to the embryo selection criteria. So if everything well stated at the beginning, patient may have better acceptance when you give them recommendations like this scenario. And towards the end, I think we're at the end of this presentation. I'm really appreciating you bear with me for this an-hour talk. Any suggestions, advices, or questions are welcomed in the following Q&A session. Thank you very much.